Hello everyone, I am Dr. Subramanian Kannan, Endocrinologist at the Narayana Health Hospitals, Bangalore, and my colleagues here on the right, they will introduce themselves.
Hi, I'm Dr. Shiva Prasad, a consultant endocrinologist at Narayana Health City, Bangalore.
Hi, I'm Dr. Kranti Khadilkar. I'm consultant endocrinologist at Narayana Health, Bangalore.
Hello everyone, I'm Dr. Basavaraj, consultant endocrinology at Narayana Health Hospitals, Bangalore.
We've come together to put together a little conversation discussion on common topics revolving diabetes. As you all know, diabetes is a very vast topic, but certain topics keep coming up again and again in our clinic as well as in various public fora, where people ask or patients ask questions which are revolving around certain theme again and again. And we thought, why don't we have this conversation and stream it across to a wider audience so that we are able to convey our opinions, scientific facts in a more understanding way. And this is sort of beginning our celebrations of the World Diabetes Day, which falls on November 14th. And as we have a series of programs in the hospital, one of them will be this recording that will be broadcasted in the social media platforms. So our talk today will predominantly be based on type 2 diabetes, and we probably would not touch upon other kinds of diabetes, including the type 1 or the rarer form of diabetes. Now, a lot has changed ever since we learned about diabetes in our medical school. When we learned about diabetes in our medical school, we had certain cutoffs for diagnosis, and then we were told that there were two main problems in diabetes. One, insulin did not work well, or you had no production of insulin. And that's how it was taught. But over the last 10-15 years, I think one thing has become very clear in terms of what is causing this metabolic problem. And the bottom line is there is a reduction in the production of insulin. So your body is not able to make the required amount of insulin, and that results in this metabolic disorder. For all of us, whether we have diabetes or not have diabetes, our ability to make insulin will gradually decline as we get older and older. But in people who have diabetes, this rate of decline, the ability to make insulin will start going down year after year, and this rate of decline will be a little faster. Now, what determines this rate of decline is the environmental factors. The decline per se is genetically mediated. It depends on what genes you acquired through your family members. But the rate of decline probably can be modulated or slowed down by environmental factors, which includes diet, proper healthy food, lifestyle, exercises, and maintaining proper weight, and more importantly, maintaining normal glucose levels. Having a good diabetes control is of paramount importance to maintain the amount of insulin produced by the body. Poor control of diabetes results in a phenomenon called glucotoxicity, where the glucose itself is deleterious to the pancreatic cells, and hence the cells cannot make enough insulin, and then you start going into this vicious cycle of not able to make insulin, sugars going up higher, again not able to make insulin, and the cycle keeps revolving around, and your ability to make insulin crashes down to quite a low level. So this is what we've learned, that the underlying mechanism for diabetes is inability to make enough insulin. And that's important. Why this is important is because when we talk about methods to counter diabetes, whether it is through diet, lifestyle, or medications, remember we are fighting against a process that is ongoing and continuous. And people sometimes feel frustrated. I do everything correctly, sir. I do the right diet, I exercise timely, but my sugars aren't coming down. Keep in mind, there is a genetic component that is driving the sugar, and that's where I think the medical help or the physicians or the doctor's help is very important in terms of getting your sugars under good control, because unless you get them under control, you will be fueling this decline of the ability of the pancreas function. The decline will be much more faster. So it's important to understand that there is a genetic component and there is an environmental component. We'll leave aside the genetic component, it's more complicated. but from the environmental component, what we can change. So let's see what my colleagues will have to say. Dr. Kranti, the first question I think most patients will come to a clinic and ask is, now that I am a diabetic, or now that I have diabetes for so many years, what should I change in my diet? So what are the changes that you normally advise? What are some of the key takeaways in your practice? And more importantly, some messages about the fat diets. Is intermittent fasting good for me? Is a keto diet good for me? Is a paleo diet good for me? So what is your message to the patients in large?
Important thing to change would be cut down on all added sugars. So added sugars includes white sugar, palm sugar, jaggery, honey. So cutting down the calories coming from the sugar in the diet, especially in the tea, coffee, is the first step which needs to be followed. The next step is just see your portion sizes. So the quantity of food you consume or the quantity of calories you consume. You need not have a drastic change in your eating habits. Say for example, a rice eating person need not stop rice and get converted to wheat or millets. It won't be sustainable. So whatever choices of your food, they need to be sustainable, and the major point to be taken care of is the portion size. So cut down on the portion sizes of carbohydrates, have more portion of vegetables, fruits. There is a myth surrounding diabetes that you need to avoid all kinds of fruits because they contain sugar. It is not that way. It's important to have fruit servings in your diet. The choices of fruit and the quantity is what matters. Try to cut down on calorie-dense fruits like banana, mangoes, jackfruit, but do include fruits which have high water content like watermelon, papaya, or for that matter, pomegranate. Again, another important aspect about fruits is avoid having juices. Try to have fruits as a whole because they will give you more satiety and they will have more fiber and it would be more beneficial to your diet. So in short, the takeaway for a diabetic diet is nothing drastic, no fat diets, no drastic steps. Be very slow to begin, have positive attitude, do whatever diet you're doing consistently with good look at your portion sizes and the type of food items you include in your diet.
Anything to add, Dr. Shiv Prasad?
These fat diets, so mainly the intermittent fasting, it's found to be pretty useful in controlling sugars and also in reducing weight. But you need to discuss this with your physician and find out what is the practical way of following it. And if you do it properly, it is effective. And about the ketogenic and paleo diet, they are effective for a shorter duration. You can use it for 3 to 6 months, but they are very difficult to follow in the long run. And we don't know the safety of these kind of diets in the long run. So don't start it by yourself. You discuss these things with your doctor and your dietitian. Find a practical way of following it. And whenever you are in a need, you should find the expert and talk to them and find the better way of following it. And the most practical diet is the balanced diet, which like Dr. Kranti told. Watch the portion and continue eating the same way by changing the portions of your existing diet.
I think the message that we want to convey across is there are a lot of diet patterns that might work. Individualize yourself. Whatever suits you might help. Get the expert's opinion. Particularly if you're on diabetic medicines, you may want to talk to the doctor before you do intermittent fasting, or if you want to do a very low calorie diet, you have to be careful not to result in low sugars. The key is consistency and also keeping the same habit for again and again. The problem happens is when we have erratic timings and continuous grazing of food throughout the day, where the calorie intake without our consciousness, we start consuming more calories. So stick to food timings, have small portion sizes, watch your portion sizes, and that will help you in maintaining a good healthy lifestyle and also help you control your diabetes better. The second question, obviously, along with diet comes is exercise. So again, Dr. Shiv Prasad, what do you tell your patients when they say, what should I do? Should I do a treadmill? Shall I do walking? Shall I do figure of 8 walking? Shall I do running, swimming? What exercise is good for diabetes patients?
Yeah, so exercise is one of the cornerstone of diabetes management. It helps in controlling sugars. It helps in managing many other things, like it helps in bringing down the blood pressure, improving the cholesterol levels, and in the long run, it prevents cardiac conditions like heart attacks. It prevents strokes, and even more important, makes you happy. So when we talk about exercise, there are two things. One is the scheduled exercise. You have a fixed kind of exercise, and the activities which you do in a daily routine. And do a exercise which is easy to do and which you enjoy. There is nothing that this exercise is better than the other one. So you can start with walking. The 20 to 30 minutes of walking every day is sufficient. When we talk about walking, you should try to get at least 150 minutes of walking in a week. That can be at a time or in a day, 30 minutes in a day. Or if you're not able to walk 30 minutes at a stretch, you can walk for 10-15 minutes 2 or 3 times in a day. And about the other exercises, like if you want to go to a gym, or if you want to try something new like a HIIT, you always should consult your doctor. And if you are aged more than 50 years, you should see a cardiologist and get evaluated for existing heart problem. So diabetic patients tend to have cardiac conditions which are without symptoms. So for a regular exercise, kind like walking, jogging, you can do it anytime. But whenever you are starting, start slowly. And don't do a 30 or 45 minutes exercise on the day one itself. You start with 10-15 minutes. Do a warm up before you go to exercise. Then keep on building on your speed and the intensity. And if you are not feeling comfortable doing any exercise, then don't do it. And if you get symptoms like chest pain or breathing problem or dizziness, you consult your physician. And the second part is being active throughout the day. So if you exercise 30 minutes and spend the remaining time sitting or watching TV or working, then it is not very useful. You have to be active throughout the day. You should not sit in one place for more than 30 minutes. If it is more than 30 minutes, at least stand up and work, or do some stretching, or go for a short walk of 5 minutes. So they say that the new sitting is the new smoking. Means the risk with sitting is more than with smoking actually. So it's a risk factor for heart diseases. It's a risk factor for stroke. So two things here. Have a regular schedule of exercise and be active throughout the day.
Dr. Basaraj, anything to add in exercise?
I do agree with whatever Dr. Subramanian sir has told, but we also see across a few patients who do come up with knee pains and having bad knee osteoarthritis, who complain of unable to walk, they are having severe pains. For them, what we usually suggest is they can do with their daily course, regular routine physiotherapy to build up their muscle exercises, or if at all they are able to get on with some of these water-based sports wherein the pain decreases, so that also is okay. Any form of physical activity is good. Sedentary lifestyle is a definite no-no.
So I think key takeaways from this discussion is that smoking is a new, sitting is a new smoking. So try to avoid sitting for a long time. In our OPD itself, we tend to sit and see patients for a long time. Now we've started taking a little break every hour or so, just walk up, maybe finish some hospital work, come back, do some work. So try to break your sitting position. People who are on the computers can stand and work, can take a little break. One another tip in terms of exercise is that walking after your meals, particularly if you don't have any cardiac problems, tends to be a very useful way to get your sugar as well as keep it under control, as well as it helps in not making you gain too much weight. So aerobic activity, good. Dr. Shubhra has mentioned HIIT. HIIT is high intensity workout. When you are going to plan any high intensity workout, ensure that your cardiac levels are checked, your cardiac status is okay. Either your physician or a cardiologist can do that quite easily. So consistency, both with diet and exercise, the word is a strong habit and consistent habit. And that is what is going to really help us, rather than that worked for that person, this worked for that person. Find what will work for you. Again, it may be an experimentation phase where you will try different things. but settle down into one and keep doing that over a long period of time. That is what is really important. Remember, diabetes is a marathon, is not a 100-meter race. So slow but steady and consistent in your habit in both diet and lifestyle. As I told you, despite all these efforts, sugars may not come down and it may still be higher. There is a factor of genetics that is involved. When you are born, your pancreas may be designed to make certain amount of insulin, and that may also decline over a period of time. So there are various newer drugs as well as available in the management of diabetes. Previously, the only two major classes of drugs that we used were ones that help the insulin work better, like metformin, or the ones that made your pancreas make more insulin, called sulfonylureas. These are the broad class of drugs that we had. But of course, in the last 10 years, we have had remarkable changes in the diabetes management. I'll ask Dr. Basavaraj to just give us a broad outline. What are the newer drugs? What are the advantages? And why we should also be thinking about using these drugs, and also possible side effects, so that people are careful about when they are on these newer drugs.
Yes, sir. As you rightly mentioned, the last decade or so has been very exciting in terms of the newer drug developments. And there have been quite a good number of classes of drugs which have been available now for the management of diabetes, unlike a few decades back. So the very two new classes of drugs which we find it very effective, or rather very commonly prescribed, are the SGLT2 inhibitors and what we call as the GLP-1 receptor agonist. As a unit, as a department, and as an institute, we are fortunate enough to be involved in this drug development and trials as an institute here. But now, going back again, I'll be discussing about these things as a class. Now, talking about the SGLT2 inhibitors, these are basically the glucurotic drugs, which means that they tend to throw away your sugars from the urine. There are a couple of agents which are available in the market, and your physician or the diabetologist or the endocrinologist will obviously choose the best one for you. And they have been shown some very good promises with regards to that of your weight loss. They do cause a pretty good weight loss, which is predominantly again a fat mass which the patient who uses this kind of drug they lose. And also there has been some improvement in the blood pressure levels independently, and certain cardiovascular benefits are also seen on adding these agents in your anti-diabetic medication regimen. So now, on the apprehension side, some of these patients, they tend to get something called as the urinary tract infection. Though the incidence rate, what I mean is the absolute numbers are not that high as compared to that of others. But yes, you have to be aware of those kind of symptoms, and then you have to discuss with your physician or the treating physician, treating endocrinologist, whenever such symptoms arise. And also there are again some rare side effects of probably euglycemic decay and something of that sort. You have to be on a regular follow-up with your endocrinologist or the physician as they advise. Now, coming on to the second class of drugs, which we call as the GLP-1 receptor agonists, they are also one of the very promising class of drugs which have shown very good effects with respect to that of the weight loss. And also they do also have some CV cardiovascular safety data set which is also there, with these drugs. The biggest drawback which I would consider with that of the GLP-1 agonists as of now, currently to date, is that they are in the injectable forms, meaning they are the drugs which have to be taken as an injection. They can be self-administered by the patient as like an insulin, and mind you, these are not insulins, these are very different class of drugs and not definitely insulins. Now, they also tend to give weight loss, as I mentioned, definite cardiovascular benefits, and they also have certain renal benefits also. Your physician, your endocrinologist will choose the best one for you. And the adverse effect side which one has to look on is basically the nausea. The patient who are on these drugs, they usually tend to have certain GI side effects. They tend to be the maximum in the initial few days, and as we go on, these tends to wane down. Please keep in touch with your physician, treating physician, and do inform them. And also the dose titration is also slower in patients who tend to have these side effects more. There are again variety of newer class of drugs which are under development. So probably as and when time arises, probably we'll come and speak back again to you.
Thank you, Baswaraj. So the two major classes of drugs which have created a complete transformation of diabetes practice has been this drugs called the SGLT2 inhibitors, or we call them as gliflozin in short, and the other one is the GLP-1 analogs. Remember, the SGLT2 are tablets and GLP-1 are injections. Talk to your physician. These are effective drugs not only for diabetes but also help in weight loss, and more importantly have benefits on the cardiac and the kidneys. So no longer are we just managing your diabetes, we are also focusing your risks of developing heart disease, heart failure or kidney disease. Dr. Shivaprasad, your experience on these drugs, you've been using them in your practice.
Yeah.
So what are some of the good benefits here that you have seen practically, and what are the cautions that you would advise people when they are on these drugs?
Yeah. So for the first time, probably the older drugs, they were reducing the sugars. They had only one function. Nowadays, the diabetes medicines have multiple other functions. They help you control your blood pressure. They help you prevent your heart attack. They help you prevent heart failure. They help you prevent kidney failure. So heart disease and kidney disease are the major killers in diabetic patients. And immediately when we use in our clinical practice, the safety issues are there, but they are as safe as other diabetes drugs. The major advantage is weight loss. Both these group of medications help people to lose 5 to 10 kgs. On an average, patient lose 3 to 4, but we have seen patients losing 10 kgs also. When we use both, we probably can lose more weight. So these are the major advantages: weight loss, cardiac and renal benefits.
Again, to keep in mind, talk to your physician, talk to your endocrinologist, and see if you are eligible for these medicines, and if so, then they will put you on the right medicine. One other common question that keeps coming around, and again this is very important for today's discussion, is about the reversal of diabetes. I think you open up any channel, you will obviously see some advertisement for a diabetes reversal program. So I'm going to ask this to all the consultants, and I'll tell you my opinion as well. So we'll start with Dr. Kranti. What is your take on this reversal of diabetes? So what do you want to tell people about it?
Yeah, so diabetes, as we all know, is a chronic condition, and what we do generally for a chronic condition is we control it. We generally cannot reverse it, is what is the norm. What happens with reversal of diabetes is, the definition per se is, a patient is no longer a patient of diabetes with any measures what he takes, generally diet and lifestyle, and then slowly, gradually he becomes free of the medications, and his sugar control or the measurements which we see are a 3-month average blood glucose, which is called as an HbA1c, comes to a normal range, and that is termed as reversal of diabetes. Problem with this definition, this is one point in time. What happens progressively for the patient? Does he remain a patient? Does he have to follow up? Is what is a very important topic. We reverse the diabetes with the lifestyle measurements, with the diet. If the patient can continue that, for few years, he might be off medications, but the caveat here is the patient has to be under follow-up. He has to follow the same diet and lifestyle, and he has to keep a watch on his 3-month average sugar. As Dr. Kannan pointed out, the pathophysiology of diabetes is such that the aging which occurs of the pancreas cannot be reversed, and it is going to be an ongoing process. So take it with a pinch of salt when we read about reversal of diabetes. Read what kind of patients were there in the program, what were their baseline values, what were the type of diabetes, and it is a one-point thing, reversal of diabetes, but it needs close follow-up, continuous lifestyle and diet measurements, and the patient is just what I call free of medications, but is not free of diabetes. So his diabetes, I would say, is not reversed, it is well controlled on just diet and lifestyle and without medications. So to summarize, it is basically needs to be taken with a pinch of salt. And it is a positive aspect, of course, needs to be taken positively, but we need to keep the monitoring in place and the lifestyle measurements in place.
So in short, it's diabetes remission rather than diabetes reversal. So it's gone into remission. Again, it can surface back again if the the lifestyle is gone back to old habits, or if your pancreatic cells again are declining. Again, Dr. Basavaraj, again, comments and thoughts?
Yeah, most of this diabetes reversal, whatever we understand, is probably because of the low calorie or the very low calorie diet which has been prescribed, and most of the programs also they do run that. But maintaining such a difficult lifestyle or such a difficult program schedule of a very low calorie diet consuming only 800 to 1000 kilocalories is quite a difficult job, and most patients, what we see, is usually fall out of the line rather than in the line. So most of them, they by default come down telling that no doc, this is not possible. So again, going back to our previous discussion, slow and consistent efforts is what we always consider as the improvement in your overall diabetes management score. But something which is very drastic, which you are not able to pull off for quite a very long time, is something which we would always be cautious of.
Dr. Shiv Prasad?
Yeah, so reversal doesn't work for everyone. So it usually works for people who are overweight, who are obese, who have a shorter duration of diabetes. So all these overweight programs, they work on only one basis, that they restrict calories, mainly the calories from the carbohydrates. And we don't know the safety of these kind of diet in the long term. So short term, 3 months, 6 months, okay. But long term, it's difficult to maintain, and we don't know the safety. There are issues with kidneys, there are issues with bones when you have a ketogenic diet in a long term, on the long run. And there are patients who are on higher doses of insulin, patients who are type 1, patients on certain type of medications. This kind of diet can be injurious, can cause serious problems. So always discuss these things with your doctor, find out whether those medicines can be continued, whether it is safe, and evaluate yourself to find out if there is any contraindications for such kind of diet therapy. So discussing is the main thing. You have to discuss with your treating doctor.
So I'll give an example. We had a patient who came in with a HbA1c of around 11%. That's a very high sugar, an average sugar running in the 300s. And then we put him on insulin to begin with and medications to begin with. And then sugars came under very good control. In about 2 months, his HbA1c had dropped down to 6.5. And in about 6 months, his HbA1c was about 5.5, which is almost in the non-diabetic range. And the patient was so happy that, my diabetes is now cured, stopped everything, never came back for follow-up, and was doing pretty well. What he would do is check his sugar in a glucometer machine once a while, and his random sugars hovered around 130, 140, and he was happy with that number and kept going along. Come 2 years down the line, post-COVID, comes back, HbA1c is back to 11.5. So the remission did happen about 3 to 6 months down the line, but again, it came back to almost the same level where it began the story. So it is important for you to keep in mind, long-term follow-up data of all these reversals don't exist. Talk to your doctor, see what is possible. I mean, we are not against the concept of doing something that will help your diabetes, but keep in mind, whatever you do has to be for a long-term goal. And if it is only for a short-term goal, it may not be beneficial. One another problem that happens when you go to a very different diet from what you are used to for taking for 30, 40 years is you change some of the, your micronutrients get changed, resulting in muscle loss as well. So you lose your muscle mass. And when you lose your muscle mass, when your pancreatic cells decline, your sugars, in fact, are becoming more difficult to control. So we have a few patients who come back after a diet program for 6 months, a year, now come back because they can no longer sustain the diet. And when now we're trying to manage their diabetes, it's the older drugs don't seem to work. So be careful of what you want to choose. Talk to your endocrinologist, talk to your diabetologist, talk to your physician, and choose the right one that is appropriate for you. Again, a single message today may be consistent habit. A strong habit is what is needed in management of diabetes, whether it is a habit of a diet, a habit of exercise, habit of taking your medications properly, habit of checking your sugars or your 3 months average regularly, and habit of communicating with your physicians. These 5 important habits is going to make you strong, live healthily, and probably avoid most of the complications of diabetes.
Yeah, always remember this line: sitting is the new smoking. So don't lead a sedentary lifestyle, lead an active lifestyle.
To my 2 points, remember 2 C's: consistency and communications. Have consistency in your habits and communicate with your family members and with your doctor.
After all that, I give my ABCs. A stands for ABC, B stands for blood pressure, and C stands for cholesterol. Always keep in mind, manage all of these things, 3 things very well. They will keep you healthy and fit.
Thank you.
Thank you very
you.
much.
Thank you all.